Good morning, everybody. I am Skip Lowe. I am Senior Risk Advisor with North Risk Partners, and I'm joined here today with my great friend and colleague,
Colton Storla.
And we are here kicking off our second podcast. Very excited about this. We have an awesome guest. We have Dr. John Veer.
What's the podcast name?
Oh, I was about to get to that.
I think people can read, but
Yeah.
for our listeners,
All right.
we're still trying to figure this out.
Brought to
People.
you by Community Connected Health. Glad
Where's
to have
that bump
everybody
chain?
here today. And so back to where I was at, I'm joined and honored to have a guest here today, good friend of mine, Dr. John Veer. He's going to tell you about his story. But a couple of things before we jump in here. I was talking to myself while I was mowing last night, and I said, I kind of realized that, and I'd been to Salt Lake City a couple weeks ago, and I ran into a lot of great folks there, and I had overheard somebody on a train that was about to go on a mission. And so if you know anything about the Mormon religion, they go on a mission for about a year, and realized that this young man is just like us. He's dealing and struggling with relationship issues and work issues and making sure his mom and dad are happy, and he was in a little bit of trouble because he overslept. He's supposed to help his dad in the yard. And I'm like, I think we sometimes, think of religions, or we think about people in different sects of the world, and we're like, oh, yeah, that's how they think. And, they're just people like us. And then ironically, as I'm walking into this building today, thank you for my coffee, by the way, Doc.
Yeah, absolutely.
I
That
was
place
stopped.
is awesome. That's actually that in a Starbucks cup.
Yeah.
Don't tell
Did you
anybody.
see all the pastries in the window?
Yes, and I didn't eat any of them.
They look so good.
I behaved.
I didn't know that was an option, but next time we do this. So I was stopped on the way into this building by a couple of missionaries from Salt Lake City. And brought me back to last night. I sent you a little message, and I said, we're basically missionaries. And, you hear people that have gone around the world, third world countries, and you hear people say, that's something that's on my heart. I'd love to do that. And then I realized, I go, what we're doing, we're missionaries. I travel to the fruited plain of Iowa. I've grown up here my whole life, and I go into these communities. I love history, and I know these towns. I've seen pictures of them from back in the day in the 1900s, and I go, oh, that's where the grocery store used to be. That's where the factory used to be. And all
When they
these
were thriving.
Yeah, and they were thriving. And that's where the railroad depot used to be. And that is where the doctor's office used to be. And I think about over time, and it's like heating up a lobster. Any good butcher will tell you, now put it in the pot and heat it up slowly so you euthanize the animal. I feel like that's what's happened in our communities. And just embarked in this very exciting journey. And so I had a nice talk and visit with these gentlemen. I said, well, good luck on your mission. And I said, I shared the same story I just bloviated with you two, and said, this is kind of what I'm doing, without going into great detail. So, just kind of launch into that, and welcome back again to Community Connected Health. And so I would also like to have the mic turned over to my good friend, one of my best buddies, and someone that's on a fellow mission here with me.
Yeah. Well, I think we just pass the mic directly to Dr. John here and tell his story, where he's been, where he's at now, and challenges, successes, anything and everything, so people can get to know who you are.
Thank you both for the invite. This is awesome. It's the first time I've ever gotten to wear full studio headset, maybe one other podcast before. So excited to be here with everybody today. And mission, yes. Crusade, maybe. I mean, there's lots of different ways in that parallel. So I'm going to kick off and kind of tell everybody. You guys, again, have heard the story, but we'll run through everything. So I'm a physician by training. That's first and foremost. I went into medicine not because I loved science and math and all that stuff that you had to do and be good at to get there. I went in because I liked taking care of people. That was always it from day one on, and met my wife in undergrad. She's also a physician. We went from undergrad in Iowa City at the University of Iowa to Des Moines University. Both ended up doing internal medicine. So I am an internal medicine physician, and started off in kind of the routine hospital world, and then outpatient primary care, fee-for-service, churning through people, doing hours of notes at night, because I refuse to sit and click on a keyboard in front of patients because it just drives me bloody crazy. Like at that time, my patient average age was about 76, and the last thing they want is somebody doing technology. So ultimately, didn't feel like the right fit, wasn't providing care the way I wanted to, and moved on to another organization where I learned about capitation and different payment models other than the fee-for-service world, which I used to have a patient, gentleman you guys actually know, who always asked me, like, hey, what do these labs cost? I only want you to get the most pertinent ones. I'm like, I have no idea what these things cost. So learned about capitation, learned about what the cost of healthcare is, which is drastically different than the price of what healthcare is, and fell in love with direct primary care. So learned about it, kind of started that in 2019, called it Exemplar Care, started in the back end of 2 general surgeons and a plastic surgeon's office, and just got going. Thought I'd have 200-300 patients, call it a career. Stumbled into a relationship with QT Quick Trip. Now that there's 2 in town, it's been tough to say that without putting in the letters, but started taking care of employer groups. Had a couple other employer groups show up and realized, okay, there's something to this. Folks need things to take care of their teams and to help with their expenditures that, I mean, let's not kid ourselves. We're at 20-some years of costs going one direction, it's up. No one ever comes in and is surprised, like, oh, your healthcare costs are going down next year. So started to grow our direct primary care clinic, moved out to a different spot in West Des Moines, which is where we're kind of headquartered at. Started adding in a 24-hour urgent care to support those employees around the primary care model of DPC, which is what direct primary care is usually referred to as. And it just kept growing, and we kept finding more and more employer groups that were interested, tried to understand how it fit into health plans, because obviously the somewhat delicate dance of employer, broker, employee care systems, like there's a lot to it. And you guys know this, these relationships mean a lot, by the way, if you're taking notes. One, we're going to talk about the 3 Bs later, not to be confused with Big Beautiful Bill, but it's about brokers, and you guys will fall into category 1, which is the best types.
3 Bs. I don't think I've heard this one.
Oh, this
yet,
is
so
new.
I'm excited.
This is breaking news. Anyways, about 18 months ago, Hy-Vee partnered with us in a 50-50 ownership arrangement. And so we have been growing and expanding. So where we were at a little while ago was in the Des Moines Metro. Now we're across 5 states and filling in various areas of several of those states. So we are in Davenport, Cedar Falls, Cedar Rapids, Coralville, Des Moines, Sioux Falls, Omaha, and 2 locations in the Kansas City Metro. Additionally, we are looking at filling in 5 or 6 other communities in Iowa in the next 6 to 12 months, and same on some outside state locations as well. So the growth continues, and it's fun. We've found a lot of ways to do this, but ultimately our team cares about delivering direct primary care, which is a relationship-based version of care where you get more time, you get more convenience, you get access. One of my favorite stories, a guy who was one of my first patients when I started, called me at 3 a.m. because I was in Beijing. It was 3 p.m. essentially for him. It's like, what are you doing? I said, I'm sleeping. I'm on the other side of the globe. He's like, why'd you answer your phone? I was like, well, that's kind of the relationship we have. You call, I answer, and we take care of you. And I did. I popped up, opened a computer, sent in an order. Once you get through the VPNs and stuff of dealing with the internet in China, it's just a cool way to take care of people. And we can talk about those stories later on. So yeah, that's kind of it.
Backtracking a little bit, you got into healthcare because you want to take care of people.
I did.
But you worked in a system or a model that wasn't allowing you to do that. Can you talk about that a little bit?
Yes. And, it's the vast majority, fee-for-service, primary care, whether it's family medicine, internal medicine, your job is to see people, to get them through panel sizes. I was at 1,900 patients When I left the system, they wanted me at 2,500 patients, which is about 1% comes in. So you get 20 to 25 people a day. Family medicine's on the 3,000 to 5,000 panel, and they often see close to 40, depending on the age and acuity of the folks they have. And direct primary care is different. So you have between 500 and 1,000 is kind of the max. Every DPC kind of sets their own amount, but given that we work with employers, you get 60 to 80% engagement. So some of those folks are there, and if they ever do come in, you've got capacity for them. So, but you just get so much more time. Yeah. I mean, I used to get 15 minutes. Someone was scheduled 30 minutes on a physical, and that included all the time that nursing was there.
Would you say time is the single biggest differentiator?
Time and convenience. The time face to face in a visit is really it's drastically different. So I had a patient of mine called on Monday of this week. I didn't know the story was coming, but called and said, "Hey, my son's really struggling. I need to get him in to establish with you and be seen." And I said, "Yeah, I can see him tomorrow morning." And he came in and we talked through what curveballs life's throwing him right now. And we were together for 75 minutes, just kind of going through, here's where we were, here's where we're at. Let's figure out a new path forward. And I couldn't have done that in another world without having a bunch of people screaming at me as I walked into the room, 30, 40, 50 minutes later.
You got 10 patients waiting in the waiting room. Hurry up.
In the waiting room. And I mean, even if someone could see the setup of our office, it's like my desk where I sit and work, but patients sit there. And then on the other side, there's an exam table, and we kind of do everything in the same place. Where in that world, it was 3 rooms. You're going from one door to the next, back to your office, next, and just around and around all day long.
I feel like that's the hardest part when Skip and I are meeting with employers for, the people that are sitting in front of us at the employer group to really think about is the time aspect. Mm-hmm. Because the Affordable Care Act says, your preventative exams are included in your health plan at no cost. But as I had an epiphany a couple weeks ago where an employee in an employee meeting was like, well, I don't even go because it's a joke. Mm-hmm. It takes forever to get in. Yep. And then once you get in, they're banging on their computer the entire time, and then they're maybe just writing your next prescription and, sending you along your way.
Well, and even initially it wasn't, yeah, they were still time constrained by the model. I always say healthcare is about as good a capitalistic system as you get. It has shaped around what you're supposed to do, but one of the ones that gets me the most is, so Skip would come in to see me in a fee-for-service model.
Well,
and
careful now.
If Skip were to come in and see me in a fee-for-service model, in my old life, let's be clear, you would come in and you'd have all of your preventive stuff included in that visit. But then you say, oh, and by the way, I have this weird rash.
Yeah. Glad you brought this
up. That's no longer prevention. So now I'm going to bill you for an acute visit on top of that free one. Yep. So we can still collect some extra dollars on the side. Yeah. That type of perverse incentive is what drove me the most crazy. And that's where I've really, with direct primary care, my incentive is to get you healthy. Mm-hmm. You being healthy is your incentive. I have a steady cash flow through a membership model. And you don't have to come in for the relationship to work. And the healthier I keep you, technically, the less you're going to use me, potentially. And then on the employer side, here's a fixed cost, and these people can now come in whenever they need to, and it's not going to change that. And we can take care of people in a lot of different ways. So those mm-hmm. 3 actually align on how you're supposed to take care of people.
Yeah, we've definitely been in employee meetings where they're like, yeah, I went for my preventative and I talked about that rash and now I got this huge bill, or my doctor told me that these labs were included and I got these surprise bills. And then as Skip likes to say, once you get those, enormous bills, they're like, I'm not doing that again. And now we got people not going to the doctor, and yet you have these, HR, leaders that are trying to launch these wellness plans. And usually part of those wellness plans is going to the doctor. Yet no one wants to go because of
they don't know what's coming out of
the time and the money and everything. So
we're seeing that a lot more. And in fact, last week I had someone screaming at me who said, "You told me Because the old days it was, and I'd say, 5 years ago, someone going for a colonoscopy, they'd find a polyp, and then they call and say,
That's another good gotcha.
Yeah,
Oh,
right.
yeah.
And so they remove the polyp, it becomes diagnosis, and all of a sudden they get a $1,500 to $2,000 bill. They're screaming at us, and you told them it was preventative. And I slow down in the meetings as much as I can with employees and say, just, if you do get a colonoscopy, they might find
With
a
an
polyp.
asterisk.
With an asterisk, right? And so now we're seeing it in the preventative side where
'Cause then it's a diagnostic,
Yeah, I
not
had-
a preventive,
Yeah.
which
Yeah.
is crazy. I just had my colonoscopy 2 weeks ago, roughly.
I saw that on LinkedIn, by the way.
Yeah, thanks. Did it with no sedation. That's where everyone thinks I'm crazy. But I was sitting there wondering the same thing. Like, I've known the general surgeon, actually, who I leased space from when I started. And we're watching, and I was like, oh, man, not a single thing. There's no way that insurance will mess us up. And that's a product you guys helped us kind of put together and implement. So I was like, they could still pull if there's something there, but there wasn't anything. So it was fantastic. I was like, oh, good. No polyp, 10 years. I'm clean, and I'm not getting any sort of additional, oh, here's your diagnostic components of that thing.
Well, now we're seeing it, and to my example, just earlier this week, getting screamed at. It was the polyp thing. Now it is. Why did they? They're not. The doctor asked him, would you like to know what your blood type is? So that had a separate code that fell outside the preventative, and so we're just seeing some of this. I don't know if I call it gamemanship. I got to be careful on that because I think that's the other golf we have in, do doctors really understand how much this costs? Are they trying to take care of their patients? And I will tell you, there's a big movement out there, and I meant to say congratulations on your award for Health Rosetta. We were just out in Denver.
Thank you. You guys get just as much credit for that as I do.
Jackie Robson, had a good time with some other clients out there, and just the movement that's out there. And the hot topic is DPC. And so there's a couple things, if we can just back up a little bit, because
by the way, for everyone watching, this is how the three of us talk. This is a big circular thing. We do this all the time.
Yeah, it is. So I'll go all over the place for us today, not naturally, but just maybe kind of going backwards, because we're going to have people that are on this podcast that are just learning about DPC. And ironically, I took a call from a hospital CEO who said, what's this thing called DPC? I'm like, really? It's kind of like back when the HSAs come out, and I'm in an insurance meeting with other brokers, and they'd been out for 5 years, and he says, what the hell's an HSA? And I'm like,
Love the accent.
And so
Is this an employer in Texas?
rhymes with Keokuk. So yeah, maybe we can slow that down a little bit. And I do have to ask selfishly, have you met Travis Kelsey? Because for people that don't know, Hy-Vee is like one of the premier grocery store chains in the country. There's a helpful smile in every aisle, just like at Exemplar Care.
Sure, on the Taylor Swift bandwagon too, huh?
So so a couple questions
It's
on the
gone
table.
down a rabbit hole.
Yeah, well, have you met Travis Kelsey? Can we get that out of the way?
So first off, I have not met Travis Kelsey. Travis, if you're watching this riveting podcast, please give us a shout out. But no, I did not. But we did laugh. The engagement pictures were in Lee Summit, Missouri.
Okay.
And so we have an Overland Park, Kansas City market, and we have a Lee Summit clinic. And I was like, oh, was that in our parking lot? Did anyone see anything? So I got a kick out of that. I learned that from one of the NPR reporters who said, oh, I used to get piano lessons in Lee Summit. And I was like, oh, Lee Summit is where our clinic is. So,
but Hy-Vee, for those that are listening, is affiliated with the Kansas City Chiefs, and so you see their logos on there. So I wanted to make that little love connection there.
I do not know Travis Kelsey. Maybe someday.
For people that don't understand DPC, it was in the Big Beautiful Bill, the other BBB that we're talking about. And so there's been a lot of traction from the brokers. I feel like, bragging rights, we've been ahead of this curve.
Well ahead.
On so many levels. I talked about Health Rosetta. That's the big buzz out there. Hint Connect, who you're a part of, because people will say, well, my employees are in this town. I don't have access. You've already mentioned your footprint, but we also have connectivity with about 5,000 clinics across the country. But so direct primary care is what DPC stands for. So let's make that connectivity there. But what is DPC for the employer to understand, as far as, I know we know how it's different. You have more time for the employees, but just kind of taking more of a fundamental approach, because it's here, folks, and it's coming to a theater near you.
So direct primary care is a membership model. So you have 100 employees, and you say, okay, we want these. There's a set rate for that. And then those patients have access, or patients for me, employees for you, have unlimited access to everything we provide as a DPC. Mm-hmm. And we always say if you've met one DPC, you've met one DPC. They all have a little bit different flair and what services are included. But one thing that we do that's quite a bit different than most is any labs we do on site, any x-ray we can do on site, procedure we do. Those things are all included in our membership. So
urgent
we don't
care,
urgent
sutures,
care visits.
You stock 50 medications, I believe, at any given time.
Say 40, but
okay.
Sure.
All right. Metformin.
Dermatology.
Yeah.
Yep. We can do skin biopsies, things
all
like
included.
that. Yep. So the things we do at that fixed cost for a member. And, if you look at the cost from an employer fixed standpoint versus what their variable cost is in a fee-for-service world, like it may be a wash. A lot of times it's better, but it may be a wash. And that's not where you get hung up on it. I know everyone's looking at the dollars, but most importantly, the employee comes in and they don't pay anything. So back to all these previous examples, They pay nothing. They come in, there's no copay. It's not going to have any bill that goes to them unless we click a wrong button and then we fix it on the back end. So you actually have that construction worker, that frontline employee who it might be living paycheck to paycheck, who can come in and confidently know they can get care that isn't going to break them. And we get way better engagement out of people who come in and say, I haven't been seen in X amount of years because I just don't trust them.
Relationship and peace of mind and removing the financial barriers to care.
Absolutely.
Yeah.
And we had one employee come in and say, out of all the years that I've worked for this company, this is the first true benefit in which the benefit comes with no strings attached. It's paid for.
What's the catch?
I just come use it. There is no catch. So we always say for direct primary care and Hy-Vee Health exemplar care, we get two things said more often. And obviously opportunities like this change that. But one, how have I never heard of you?
Yep.
And two, this is too good to be true. Yep. And so they're having
Sounds
the conversation.
familiar.
Yeah, they're
then
having
once
the
they
conversation.
experience it, they say, this is what healthcare used to be.
Correct. It's I always say it's Norman Rockwell medicine with the little guy standing on a chair with his pants half down, getting taken care of by the family doc in the community, but with technology added in.
Well, I think the surprising part too I think it's easy for employers and employees to buy into the DPC model because of the time, the relationship. But I think what some people fail to realize is how much you can actually do in your office setting that in a traditional fee for service, they might say, oh, we need to refer you to cardiology. We need to refer you to dermatology. We need to refer you, which just creates more money that they need to pay. And then also I want you to maybe get into, your cost of, providing these services, especially with labs. That's the one that we see most widely marked up
Labs
service that people are like, wait, these aren't actually $2,000. They're less than $20. And so we're trying to explain that to employers that this is a better care model, but secondarily, your claims are a reflection of your premiums. So direct primary care is a membership. It's not a claim that hits your plan. Oh, and by the way, by getting these services through the direct primary care,
they subtract out other things out of the claim bucket.
So if we can reduce the claims, we can reduce the premiums.
Correct. So labs is probably one of my favorite things. A couple stories. One, I had a gal who came in and she had been seen in a clinic a couple counties outside of where I was practicing. And she said, yeah, I just need something different. I went into the clinic I've gone to my whole life. And first off, I was told it was I was a new patient. It was a new patient visit because the independent doc was squeezed out and bought up. And so she was a new patient to the system that took that over. And then she'd always gotten her price of labs. She knew exactly what she'd paid every year. Well, this time her urinalysis that she got every year came back at $197. And for those who don't know, a urinalysis is literally taking this little stick, dipping it in some pee, looking at the colors and going, yeah, you do or don't have anything. And getting out of, I said earlier, I didn't understand the pricing as a physician practicing. But now I have these negotiated rates that we've gotten, and the wholesale cost of that to us is $1.30. So $197 for a test that costs $1.30. That's a pretty good markup if you can get it. But I did that through all of these things. So let's say a routine annual physical. You have a CBC, which is blood counts, a CMP, which is kidney, liver, electrolytes, lipids, which is your cholesterol, A1C, which is checking you for your diabetes risk, and potentially a PSA for a male for prostate cancer, urinalysis. So kind of off that baseline blood work, it's like between $9 and $11 wholesale. And I've had people come in and they said, "Oh, I went to a testosterone clinic. I had $400 worth of labs drawn, and it's all the things I just listed, plus the testosterone, which is a whopping $4 wholesale. So now we're up to maybe $15, certainly not to $20 yet of what that actually costs. And in a membership, they were so low when we learned about them. We're just including them because this is like the membership price is priced, and we haven't increased our price in 6 years. So our price has kind of landed where it needs to be. But it's just highway robbery on the labs. And I get that, if you look at the reimbursement from insurance fee for service on primary care for physician wages, they've actually gone down compared to if you're following for inflation. So I get that there's other ancillary things making up for some of those losses that just haven't been decreased yet.
Well, and you have the downstream impact where you go down to one of the greatest institutions in the country, Go Hawks, University of Iowa hospitals and clinics, and any medical school for that matter. We don't have enough medical students going into primary care. And what was a stunning statistic, or at least you can fact check me, but the cost of medical school, whether you're going in for orthopedics or primary care, is the same price.
Absolutely.
So they're looking at the economics, right? They're going, well, when I get out of here, I'm going to have $325,000 of medical debt, and I can be a surgeon, which, there's going to be some additional years there, but to get that medical degree, it's the same. It's the same.
Is. And there are some schools that are starting to look at how do you shorten a year for some of these different things. But the cost it's not uncommon to see people with $300,000 now in medical school debt. Back to incentives drive people's behavior. And I have two things. So one is Dr. Garrison Bliss, if I forget, remember that. But one of the most controversial things I think I've ever said out loud was at an American College of Physician Iowa chapter meeting. I was just graduating from residency, and we were sitting there with a bunch of my mentors from around the state, and they were lamenting how few people were going into primary care, specifically internal medicine at that time. A bunch were going in so they could do cardiology and gastroenterology, all these different things. And they said, "Why is this?" And I said, "Guys, I don't know how else to put this, but if you look at what the average salary for a gastrointestinal or gastroenterologist is versus a primary care doctor, and you look at the loan amount, like you're making, if you were saying I'm making a fiscally responsible decision, you would never go into primary care. Ever. I mean, it is a fiscally irresponsible system." And they said, "Well, that can't be it." I said, my example, this was a Saturday morning. I said, if on Monday morning you told all the gastroenterologists, we're going to just do something fun this week. We're going to flip the rate of reimbursement for a colonoscopy versus a clinic visit. I said, where do you think everyone would be on Monday morning? They would be sitting in their office, and within 6 months, the American Gastroenterology Society would have papers about how office visits with GI docs are the greatest thing you can have, and any tech can go do a colonoscopy. And they were like, you can't be serious. I was like, this is just economics. We all do what you're incentivized to do. So long story coming back. So Garrison Bliss started DPC late 90s, maybe 97. And had the pleasure of meeting him about a month ago. And he said, the way I looked at this was anything that I was doing to take care of patients, I shouldn't be looking at is this financially good or bad for
Yeah.
me? So if there's any, like the labs, that's why we just throw them in. If we got paid for every lab we did, then well, we could do one extra here. That wouldn't hurt, and a little one over there. But if you just bundle it in, then we don't have a financial incentive on whether we do or don't get more.
Well, and I think primary care physicians that are a part of larger healthcare systems in themselves, they're blind to the economics of this, and so this story is playing out across this country, where we have burnout, and we heard that it was exacerbated during COVID-19, and we saw all these doctors that were just getting out of the business of medicine, and we saw nurses that said, "I've had enough," and I've been living in a prison, and they decided to go 90 degrees against the economic angle to try to help themselves out. And then we also saw the explosion at DPC, where doctors left the big system. There's got to be a better way to deliver healthcare, and it is super exciting. And in your model, again, this is happening across this country. But you know what I love to say at this point? Everybody remembers zero.
Amen. I'm
Colton
pretty
and
sure
I
I still own that website.
ya?
Remember Zero.
Okay, good.
RememberZero.com
All right.
or .org or
All right.
something.
We're taking donations. But that's the thing people have to remember, that 90% of your care can occur at a primary care physician's office. And so Colton, and we talked about our mission earlier, we really are at the point where we're not going to sell a health plan, in certain sizes unless we have the bolt-on. And my epiphany, and my seminal moment of this is two things. One is I was in Washington, D.C., also celebrating your award back in 2024.
Or, yep,
We had
last
a lot
year.
of fun there.
We did.
And I wasn't feeling so hot at the airport. And I said, "Hey, Doc, can you maybe take a look at something that's, kind of been irritating me?"
Where was that located, Skip? Not the Uber that we were riding in.
Was it in our, was it? Yes, it was in the Uber, in fact.
But
Yeah.
it was at a belt line, I believe.
Yes. Yeah, it was it was an awkward moment. So yeah, whoever thought I would be
Dropping trow. And
dropping trow in the middle of, but that was also a DPC moment, and there's been others with you. But
We could have taken you to an urgent care or emergency room.
Yeah, well, it was
Sounds
a heck of a
expensive
time
and
trying to find the medication. But thank you again for that. But the accessibility, and really, I'm going with this is that I've been in employee meetings now. We've been doing this a couple of years, and you've heard this. They say, you can change our health insurance provider, carrier, but don't get rid of you.
Yep.
And that was really that Rubicon I crossed, and I go, yeah, we've arrived.
There's definitely a stickiness to the care, and it's funny because it's not necessarily the C-suite. They like it, but their employees literally come back and say, "We need this. This is really helpful to us."
I'm glad you said that, because you have a lot of executives as clients or patients.
Absolutely.
And it's like, well, if you enjoy this benefit so much, why wouldn't you want it for the rest of your employees? So there's this preconceived notion that, well, this is only for, the upper class.
Correct,
And it's
and
like,
it's not.
No, everybody deserves, primary care. And
access.
I think my epiphany was also last year. We were already doing direct primary care, believed in it, but I was at the TPAC conference, and they're a stop loss underwriter, and so they are trying to find innovative ways to not pay claims.
Yep.
So I was like, okay, yeah, we've got these pharmacy solutions, we have direct contracting, we've got bundled surgeries, we've got DPC, we've got carve out programs. I can go to any employer, or we can go to any employer and say, hey, we can lower your unit cost of your claim, pay less for a surgery, pay less for a drug, pay less. But there's a point where we've unleashed all these strategies to lower your unit costs, where now we just need to get people better. So then we can avoid those high cost claims. And so doubling down on primary care so they don't become the big stuff.
Absolutely. And I think that's
is a no-brainer.
From my practice standpoint, I remember so clearly, I can see the room I was sitting in, talking to a guy about the fact that he was pre-diabetic. And I said, you got to work on your diet and your exercise. I said, right now, the data at that time was relative risk reduction of about 16. If you started metformin. You started taking what would later become a diabetic medication if you got to that point. But
Which you stock. Sorry.
what was that?
Which you stock.
Yeah, oh, yes.
Yeah.
Of course we
Well,
stopped
let me
that.
get that out.
It's something that you do, and it lowers your hemoglobin A1C, the amount of sugar added onto your red blood cells. And I said that's 16% relative risk reduction. If you change your diet and your exercise, it's 32%
Double.
reduction. Yeah, so it's twice as good to exercise and eat fruits, vegetables, lean meats, and healthy foods. He's like, all right, yep, send the script in to Walgreens. I'm like, well, that didn't go quite as I wanted.
Yeah.
Where now I have the time and I spend a lot more time like, all right, you are pre-diabetic. This means your body's not dealing with insulin. Insulin's not working correctly with your body to drive sugar into cells. So let's talk through how you do that. Here are the dietary changes, and you go through, okay, first off, if it's in a plastic wrapper, it's processed and it's probably not ideal for this. If it's got a bunch of extra sugar added, it's not appropriate, like fresh fruits, fresh vegetables, chicken, lean meats. Like these are kind of the baseline whole ingredient foods that you can eat by themselves, not smashed together and put in a package. And then exercise-wise, for diabetes, it's high-intensity interval training, which if you're out of shape, you can't go from 0 to HIIT. It's not functional. But you can start heading in that direction, and starting with, I always tell people, if you do 30 minutes of walking every day from today until the next time I see you, you will be probably 5 pounds lighter, and you will feel better, and your pants won't fit the same. That's borne out in a lot of components, but you start moving them towards that, and you can show. I now have a group of people. I can say this has no, like, there's no issue. They all improve if they do these things, and you don't have to become diabetic. And if you don't become diabetic, then you don't start worrying about the apathies, the triple apathies. So there's retinopathy, nephropathy, and neuropathy, which is number one cause of vision loss, diabetes, number one cause of dialysis, diabetes, number one cause of amputations of important parts of your feet, diabetes. So you have the ability to prevent getting a disease that over time is going to slowly have you whittled on. And those are the microscopic impacts. The big ones are the cardiovascular, which is heart attack and stroke. And so people are like, well, I don't really care about my pinky toe, but I don't want to have a stroke. I don't want to be living in a nursing home unable to move part of my body. So having that time to do that's really important stuff.
Yeah, I was at an employee meeting last year of a new client. We were adding direct primary care, and we did, the education around the health plan, did the education around the direct primary care, and the gentleman pulled me aside, and he was type 2 diabetic, and I think he was going to Mayo Clinic, and he's like, I understand they're a great institution for the big stuff, but the day-to-day stuff, he's like, I've had constant turnover with my doctors, and I've yet to find a doctor that will spend the time with me to get me off these medications. So unlike the gentleman that you were talking about, this guy was like, I know that I can come off these medications. I just need someone that can spend the time to educate me on how.
Yep.
So
and it's
he was
hard work.
super grateful for that. But I think people, there's some people that have that mindset of, oh, once I'm prescribed a medication, I'm going to take that the rest of my life. And you almost have to, instill that in that person that, hey, you don't have to be on this medication the rest of your life. Yes, some you will.
Yep.
But there are lifestyle changes that you can make to do that.
And there was a big kerfluffle earlier in the year, maybe late last year, where they basically said that the GLP-1s were like now first line for diabetes and weight loss. And then they said, oh, yeah, well, we meant lifestyle changes are still included. But and I've seen this in fee-for-service churn and burn practice. You've got people who you tell them, yes, you need these lifestyle changes. You don't go into any detail. 3 months later, they haven't done it. 6 months later, they haven't done it. And now they're full-blown and you're treating them. So, I mean, I get there like, that should be there. But I don't know how you impress upon people like those things need to be front and center, and you have to have time to educate them, or you have to have resources to get them to a dietitian, to a health coach, somebody who's going to hold them accountable and actually get those things.
And maybe
happen.
it's, mental health related, because I was sitting on a
Exactly where
webinar.
we're
Stress
going.
eater?
Yeah.
Yep.
Yeah.
Because Cleveland Clinic did a really good webinar, and they had a dietitian, they had a pharmacist, they had someone that specialized in, what is it? Trying to think, what's the other weight loss surgery? Bariatric surgery. And so there's just like, there's a time and place for all these things. And so, but if you're just masking it with a GLP-1 or with bariatric surgery, the chances are they're going to, gain the weight back. And if you're not really spending the time with them again, to learn, are they a stress eater? Is there something that happened, in their early years of life that, they've got eating disorders or things of that nature, that people just fail to, address.
Yeah. I mean, it's usually not just a discipline issue. There's chemicals, there's stuff that if you don't help right the ship and hit some of those underlying things, discipline only goes for so far.
Yeah.
Motivation only goes so far. And then you have to, and that's one of the things I tell people is you've got to change the routines. It's no different than smoking cessation. Like if your habit is to wake up, go outside and smoke, then your new habit needs to be wake up, don't go outside. And like you have to start changing all those habits that your body does on autopilot. And the same thing's true for food. Like, I always joke, I drink a lot of Starbucks, and I switched my order up about 2 years ago. And on January 2nd, I was headed to the office. And I did it, and I had to correct myself because I screwed up and did my old order out of habit. And I did this for a month, and when I switched that habit of what I ordered, there were 4 times I got to the office, and I was like, I didn't stop at Starbucks.
Yeah.
Like, I completely broke this habit loop because what I was getting was not the reward that my brain was used to. So it's like, all right, scrap that and move on.
Well, it doesn't help that Starbucks is in your parking lot.
Well,
in West
that's
Des Moines.
the second one.
was
I
gonna
usually
say,
do the Johnston
You could take a
one
wheelchair there if you wanted to.
historically,
right?
yes. Yeah.
Well, maybe we can switch gears and talk about all the fun we've been having with employers.
I got to interrupt you because there's one last little teeny component to here that's going to wrap this up in a nice package, and that is mental health. And those are services that are also, I don't want to say fully included, but that's part of what you do.
Absolutely.
Because this is going back to mental health. It's your decisions, and then we're going to go on to that. But I think the listening audience deserves to know in this DPC package. Because I really want to make sure we also address friends of the program of, when someone needs something more acute. But mental health is...
So, absolutely. I actually gave a presentation earlier this week, and this was one of the questions from the audience was, what about mental health?
Yeah.
Like, whenever you're talking about a product, like, what is that component? And I said, that's probably my favorite part of DPC is by far and away the most common mental health disorders are depression and anxiety. And by far and away, good primary care can address both of those things. Therapy may still be needed. Some point, complex medication may be needed. But the time to sit and talk through these things, discuss the pros and cons of medications, the pros and cons of therapy, what the treatment outcomes between the two look like, how you manage stress for anxiety. And I always tell people, and this is why I have a real passion for this, is I had panic attacks my second year of residency. And the only time I wasn't anxious and on the verge of a panic attack was actually inside the room in a hospital. So I'd go in and I'd see somebody in a room. I'd walk down the hall, start freaking out, go in a room. As soon as the door closed, I was good. But I needed a lot of help to get that managed, and it took a multidisciplinary team. And so I love when people will have those conversations. And because we have the time and you build the trust, you can manage that right there in the primary care office.
Yeah.
beautiful.
Super important.
Yeah. Wanted to get that in there because that's old-fashioned medicine. And when you get to turn back
Mind,
the clock.
body, everything.
Yeah.
Take care of the person.
Yeah.
Yep.
Go ahead, Colton.
No, I mean, I've seen that firsthand. My dad, he's type 1 diabetic. And, I think he was diagnosed when he was 7 or 8 years old and lost his license when he was 20 years old because it started to take his eyesight. And, it's progressed from there. But, now he, can't drive, can't work. and just trying to manage, his A1C, his blood sugars, everything. But yeah, if you aren't managing those things, it does turn into, a mental health crisis.
Absolutely.
Because now you're, stuck at home, not being able to do certain things
Yep.
for yourself and things of that nature. So yeah, definitely important piece of that.
So where were you going to take us next on this journey?
The employers. When we first met, we got a little tour of your facility, which was great. And we didn't really know where this journey or, friendship was going to go from
Can
there.
I hop in on that?
Yeah.
So literally these two came in, took the tour like you said. They left, and I went down the hall and went, huh, those two were interesting. I have no idea what they're doing with their lives. Like we talked about, I think 411 plans
Yep.
for
Yep.
firefighters,
Yep.
like all these
Yep.
different
Classic.
things. And I was like, who are they? They're almost speaking a different language. And we'd all talked about how we'd all kind of been in the Health Rosetta kind of mindset of things don't need fully bundled in a PPO product. Like here's how you blow them up and build the healthcare stack that takes care of you and your employers. So I was like, I don't know if we'll ever see them again. And about 6 months later, they came back and said, hey, we've got this great new idea, which that one was a wild party.
We learned some things.
If you know,
along
you
the
know.
way.
Yeah.
But we
Thanks for being the guinea pig,
Yeah.
because we're much smarter.
Absolutely. And so we started to do this fairly frequently and have gotten really good at putting together the pieces to take care of people.
Yeah.
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 You want to talk
So
through that?
you were your own first case study. So working
We
with
were.
Blue Cross and Blue Shield, seeing an increase
Yep.
on about maybe 30, 35 employees. And you were like, well, if I want to take this strategy to employers, we need to figure this out.
Practice what you preach.
So, looking at an independent TPA, looking at an independent PBM, we worked with a
Transparent
regional
PBM.
regional network, and bolting on the, direct primary care with the major medical, because that's the number one thing that we get from a question standpoint from the C-suite. Okay, direct primary care sounds great, but how does this coincide with or work with our,
How do I
our
go to the
health
hospital?
plan?
Yep.
And yes, you can, attach these services to one of the big insurance carriers, but you're not necessarily doing yourself a financial favor,
No, you're
because
definitely not.
they're also saying, well, we've seen increase after increase, and now you're asking us to pay for this additional benefit.
And on a fully insured plan, you're not
benefiting.
We can save Blue Cross Blue Shield or some other large insurance company a bunch of money, but that's never what I set out to do. Setting out to save the employer dollars so they can take care of their employees was the goal.
Yeah.
And so
So we were able to, add the benefit, reduce the cost, reduce, deductibles, premiums, everything, first year. What were
And
you able to
second
do
year.
with that savings?
we were able to wrap it back into other benefits.
Yeah.
And then it also allowed for extra cash flow in the expansion, trying to get everything up and running. So those dollars could be added back into taking care of the organization and the employees that take care of the people that we take care of.
Yep.
And I think, we had looked at it, Colton, and it was from when we first implemented going self-funded, level funded, and moving through the last 3 years. I think we're at almost $750,000 in savings, despite the fact that we've doubled our enrollment. So the standard rate increase would have been really, really harmful to our business.
And that's happening to businesses across this country where they can't invest in R&D. They're making tough decisions every year where they pass the cost of the increase onto the employees through contributions, and we raise deductibles. And so now we have people that are functionally uninsured in this country. And I think it's also important to point out, when we blow up the health plan, I love that, it's going to be my new one, and we rebundle it with like-minded folks, we get decrements in the reinsurers, and they know that we're
Absolutely.
playing ball. And we have reinsurers that say, look, we're really like you and Colton, but we're not going to work with you unless you plug in a DPC model. And so this is also being repeated with our employers. And seeing that other side of the coin for me is, again, another moment of truth where No, we wanted to do case studies, and I kept on telling Colton, I said, this is going to be really hard to sell this type of product because people are saying it's too good to be true, or they'll say, you've heard employers, now that you've jumped into the broker wagon kind of, where you sit in front of employers, they're like, well, we've tried these things before. It's been a disaster. And, the people that are making these decisions are not necessarily economically fit to try to really understand the complexities of this. But when I have people calling me literally, and I know I'm on TV here, folks, but they're in tears because we do have friends of the program when they have acute issues, when they need
Absolutely.
an MRI or they need to have surgical services for musculoskeletal. And we actually brought in a bariatric surgeon in our program now. So when someone calls up and says, I didn't have to pay $3,000 for my deductible or my out-of-pocket maximum. That's a huge thing for
a functionally uninsured,
Yeah.
somebody who's lived in that world. And for those who don't know what that means, it means you have insurance, but you have a $5,000 deductible, and you don't have. Well, yeah, that was middle of the road.
I was going to say, it was,
Despite the fact that you're $20,000 in on your family plan and premiums, you've got a bunch more.
That's
you
your
have to pay
first
out of.
deductible.
Yeah, well,
Yeah.
exactly. Then you got to get all the out-of-pocket paid to get the product to do anything. I mean, it's just insane. So that's what functionally uninsured really means is you can't afford to use the product you have, which we
we got real
on earlier.
creative. I mean, we made up our own language. I mean, what was the deductible for this, by the way?
I had no deductible.
No
I just
deductible?
paid for
Okay.
a price. It was weird. They had a price point listed up on the board. And I was like,
You knew the price
cash
before
price.
you paid for the coffee.
crazy, isn't it?
Whoa.
Can I tell my favorite story?
I want
For
your favorite
anyone here, I've told this story more times than I can count. So who wants to go to Walmart with me?
Let's both go.
Okay.
That's all of
Okay.
us.
I'll
We'll roll together.
think about
We're a
it.
team.
This will be even more fun. Okay. Skip doesn't want to go. Colton and I are going to Walmart. Most people who've ever been in a Walmart know that the TVs are on the back in the middle. And every size, not shape, they're all rectangles. Anyways, Colton and I go back and we find the perfect 60-inch flat screen TV. We agree it's the right one. We want it. And we take it. And Colton goes up, and Colton's smart. He checks out, and they said, "Thank you, sir. That didn't cost you anything." Or let's say it cost $200. And he said, "All right, here's $200, and off you go." But there hadn't been a price tag back there. They just checked out, and it was $200. And now I scan mine, and they're like, "Well, yours is $2,500." I was like, "Wait a second. I just bought the same TV that Colton did, and his cost $200."
Yep.
Well, yeah, but you're paying with a different card, and it doesn't get the same prices. I was like, okay, well, then if it's $2,500, I don't think that's worth it for this TV. I don't want it. And they're like, no, you touched it. You've already used it. It's yours. You now owe us $2,500. That's what shopping in healthcare is like. You have no idea what these things are gonna cost you, and you have to go get them. You're at a vulnerable point in your life, and you have to go get care.
Yeah, yes.
And they can hold you over a barrel,
Yep.
where at least in this made-up case at Walmart, like you could smash the TV on the ground and run out and try not to get caught. But it's just shopping is not a healthcare thing that we're all trying to reintroduce. Here's the transparency.
Yep.
Go to the more affordable one. Let's incentivize an employee to go to a provider we know is more cost-effective with good quality, and then we're going to reward them by saving them money out of their pocket. So their incentives are now aligned with their employees' incentives, and it's just such a better way to do things.
It is. And when I sit in meetings when we sell these custom plans, I poll the audience, or I'll just ask a question. Who's your insurance company today? Because, it's usually October, November, we're doing the enrollment meetings. And you know what the answer is, right? It's the canned answer. And I think people have been conditioned to believe that their health insurance card is actually their doctor, right? And so the narrative's got to change, and that's what we're here to do. And we say, who's the insurance company starting January 1st? And someone's been smart enough to look ahead into the materials we provided them, and they'll throw out a PPO network or a TPA, and I'll say, well, you're not quite right there. You're the insurance company from this day forward. So, because we all we do is spend time pointing the fingers about, geez, I need to get this thing down from the ceiling here because I'm an animated guy here. I'm a little bit of a drummer too. So, we spend all this time trying to educate people about their health plans. However, the narrative's got to change that And we also have this finger pointing going, and it's the insurance company's fault. It's the doctor's fault. It's the pharmacy's fault, the pharmacy benefit managers. It's the broker's fault. And certainly there's enough blame to go around, but we get nowhere on that. And so when you change that narrative and say, I'm going to be back here, you're going to see me a couple times this year because we're going to have a check-in meeting. We do it mid-year to make sure, do you understand that we can get you to $0 on a number of things beyond DPC? We want to make sure we're getting all that education out there. But next year when we come in here, you're going to have to start pointing those fingers a little bit at you and yourself.
Yep. If you're not happy with how it's going.
Yeah, because what is it? We call it the insurance literacy is at an all-time low.
Yeah.
You sit in these meetings.
People don't understand
Poor
what a
Logan.
deductible is.
He's had to sit here through all this.
But
that's because you have co-insurance,
we need to
copay,
simplify
deductible,
it.
principal,
Change the vernacular.
Yeah.
out-of-pocket max,
Yeah.
family out-of-pocket. Like there's
Their eyes have already glazed over and they've fallen asleep. But yeah, I mean, even with employers, they are, moving to these high deductible health plans. And they're like, well, we need better consumerism.
Yeah.
but they don't have the tools unless you implement
that's what I was
the
gonna
pieces.
get to.
Yes.
The tools aren't out there. They're starting to surface where you can know cost, you can know quality prior to service, but you need to make it easy for the consumer to do that. And, in some cases that might mean another mobile app on their phone, which is a step in the right direction. But how I see
Even
it,
that's work.
Start with your direct primary care doctor, because as you mentioned,
Have a relationship.
we've got friends of the family now,
Yeah.
and you know where to refer for the high quality, low cost MRI. We know where to
Absolutely.
refer for, the joint replacements. So we've already done that work for the consumers, so then they can just
just a
focus on
roadmap.
getting better. They don't have to focus on the financial piece. So, after your group, we went to a manufacturer, and, they're, lower waged earners. And we launched
They've
that
eaten it up.
program. They love it. We were able to reduce their costs and include direct primary care. So this isn't going to cost more. It's not going to.
Usually not, no.
We went to, Hilltop Tire, another one. Des Moines Orthopedics, proved that it worked for them.
Another Rosie Award winner, by the way.
Another Rosie Award winner. So this is what community connected health is all about. Finding healthcare right in your community, cutting out the profit, sucking middlemen, creating these direct relationships.
Skim. All your dollars just getting skimmed places.
Well, and we're seeing the money. And that's, again, part of that other side of the coin. We've got these case studies. We have the testimonials.
Yeah.
And whose money is it?
Yeah.
It's yours.
It's ours.
Yeah.
Right? And so that's what we want to do. And that's how we're going to restore our communities. We talked about the mission trip at the beginning of this discussion. And when you're seeing that happen, when people are having that extra $3,000 or $5,000 or that $100,
Makes a big difference.
I just talked to a HR director because we were dealing with a difficult employee, and they have direct primary care. They did a complete overhaul of their plan, moved from one of the big carriers. We matched their deductibles. They were on a high deductible health plan. We actually added copays, so actually they have a little bit better benefit. We added a preferred provider tier where they can pay nothing. We added direct primary care, pay nothing. And she was trying to seek services at a preferred provider, but also had the choice to go to Mayo Clinic. And so the HR director was explaining that to her. And she goes, so you're going to make me pay more if I go to Mayo? And it's like, no, we set your deductible the same as what it was last year.
Yep.
We're adding benefits to
So
your
these
program.
are lower cost options. If you want them, you can go to the same stuff you had
So
last
it's no
year.
different than what you had before. We're now
That's how
adding.
we've been doing it.
And so this employee, we did some additional education 2 weeks ago at a health fair, and just trying to educate them that, hey, we're not just driving you to a 1-800 number. You have resources. You have the tools to help you. You've got the Northwest Partners team. You got the nurse navigators that you can call. You can call your direct primary care doctor. The resources are there. It's really up to you to use them versus just saying, hey, here's an insurance card. Figure it out. Good luck. And so
That's the way it used
it's
to be
just
played.
education and re-education. But the case studies, the testimonials that we're getting from the groups that we've worked through thus far, I mean, it's been positive. It's not all about financial.
No.
And Iowa's been
yes.
very difficult. And we talked, again, we were out in Denver, and multiple times I talked to reinsurers, and they said, oh, you're in Iowa. Oh, that's like, That's a
It's
no-fly
tough,
zone.
but
Yeah.
I think we've cracked the code. If people are willing to do the upfront learning and figure out how to implement these things. So,
Yeah.
and I think you're right. The experience, we always say our NPS scores north of 80, 85 all the time. So again, that patient experience is a quality metric that matters to people.
Two last things. The data.
We've got to be over time, Skip. Go ahead.
Data. I just want to let everyone know we are getting the data, and we're seeing the opportunities of
Wait, so you can make real decisions, informed ones?
And so
Great.
people are, instead of going to the ER at 3:00 in the morning, they're going to your clinic. And for someone that has simple as a pink eye, which is about $1,400. And then the last thing is the BBB. And then we'll wrap
Well,
up
yeah,
here.
let's hear the triple
Yeah,
B
that's
that
it.
you're alluding to.
So this is, I still don't have the wording perfect, so all of you bear with me. Don't take too much offense. This is about brokers, agents, whatever you call the person you work with to come up with your benefits. There are the best. I'm sitting with two of the best right now.
Oh, boy.
So the ones that have gone out and done more to learn how you can actually impact an employer's cost. The second B is where I get in trouble. Busts, bums, worst case scenario, bought. These are the brokers that have an easy button they can hit. You'll get your guaranteed renewal increase every year. They may talk a good game and show you a bunch of other stuff, but
tell you they did everything that they could do.
always bring you
We
back
scoured
to
the
that-
market.
to that same thing of which I always said, how much is a logo on your insurance card worth to your company? 10,000, 100,000, a million, 10 million. So that second B is the touchy one. If anyone wants to live source the best term there. And then the third grouping I always say here is the buddies. So it's your HR director's cousin's brother has always been the company broker, and it's a family friend essentially. And so you have the best, the busts, and the buddies.
Yeah.
And you really, if you don't run the rest of your business off of buddies and you always try to make the best business decision, when this is at the top of your P&L, you really have to take the time, the top of those expenses on your P&L, you really have to take the time to go out and find the best brokers to work with and really dig into this just like you would any other part of what you deem your business. And I've had more employers say, well, healthcare, I'm not in the business of healthcare. Well, looking at that expense line, I think you are. So
My favorite part of it all is when we go out and do we do a presentation with an employer. You're sitting with me at the table. There's nothing more credible than bringing a healthcare provider to come in and talk about what you do.
We're not bringing another insurance solution. We're not,
We got the
saying a
best
captive's
discounts.
going to save you or anything like that. It's
there is no
providing
one size fits
true
all.
Yeah.
health care
Yeah.
to your
That's
people. And if you
the
can
moment.
get the providers or the doctors or the surgeons on board, I mean,
a
you
big
talk
win.
to anybody that works in healthcare, how much do they love insurance?
Not much.
And so it's like, why would we not create an environment where we're removing the middlemen and creating these direct pay relationships? But one thing I wanted to say on your triple Bs, I can solidify that because I was at the Free Market Medical Association and we did these regional meetings, and there was a lot of other DPCs in the area or in the room, and they're like, well, where do we find a good broker? Because every single time we go to an employer and sell them on the direct primary care concept, they're like, we love it. How do we do it? Talk to our broker. And then the deal gets shut down. Well,
Some of us have learned through painful years of experience.
Yeah. And then same thing. Went out to Ortho Forum. They invited me out to do a speaking engagement on direct contracts and creating some of these direct pay relationships. And I kind of drove everybody to my LinkedIn to look at some of my content and education. And some people, I think I saw like 15 people view my profile. And then a couple people came up to me afterwards and like, well, my broker, we're fully insured. We're being told we need to go self-funded. So my broker showed us, we're with one of the big insurance carriers. They showed us the level funded option, but it was 40% higher. And it's like, that's where the knowledge gap just ends.
Yeah.
Because most brokers only know how to sell
something
big
that
insurance
comes with a
carriers.
price tag, and you just move it
A
forward.
price tag and a logo. And it's like they haven't taken that time to educate themselves enough to say, okay, are there independent TPAs out there? How do they make money? Are there other PBMs out
Who's
there?
incentivized by what?
Yeah.
Yeah. So I was trying to do
big
some
deal.
education to get through to them,
It
but
is.
it's
Big stuff.
complex.
Yeah.
Trying to bring it all together. But at the end of the day, you have an insurance plan. It has a TPA. It has an insurance, component, a network, a pharmacy service. It's off the shelf.
Yep.
It's
Or
insurance.
well, let's build something from scratch
And
that actually truly benefits you and what you're trying to solve for.
And I think the most exciting thing, and thanks for all those who've worked with us as we've gotten through this, some of those initial things, adding in point solutions, some of them kind of felt like Frankenstein plans, like kind of hobbled together. And
Yep.
through years of iteration now, they're functioning much more like that fully insured product,
yeah.
minus the expense. So
Well, and I
thank you guys for all the hard
Yeah, I
work.
appreciate
you
it.
did
We're going to end it on that. But at breakfast the other day, we actually had a tour of these virtual credit cards that are coming out for these direct contracting. So very exciting. It's an honor to have you here, Doc.
Thank you both. Thanks.
Thank you for all the things you've done for my family.
Oh, gladly.
Yeah. And me.
I mean, if you keep me
What we
happy,
do.
we're happy.
I
I was
saying.
just out in Milwaukee and I found out I had poison ivy. Who did I call? Got a script. It was
Yeah.
hard to find a pharmacy, but
Yeah, that was a
got it taken care
number
of.
of Walgreens that weren't open.
Yeah.
And he's like, this is where I want to go.
Well-
That one's closed. That one's a specialty pharmacy.
My other option was to just go through the pain for 3
Yeah, no.
days or
Yeah, no.
go to the
Poison
emergency
ivy's
room
no
or
fun.
urgent care. So thanks for saving me some dollars.
Yeah.
there.
Absolutely. Thanks, guys.
Thank
Yes.
you.